Welcome to the Hospital Medicine Unplugged podcast. Today, we're undertaking a deep dive into a clinical practice that, well, despite strong guideline recommendations, still feels pretty pervasive in the acute care setting. We're talking about thrombophilia testing in hospitalized patients who present with acute venous thromboembolism, or VTE. Our mission today is really to synthesize the current evidence, understand the true utility, the optimal timing, and maybe most critically, how we can avoid causing unnecessary harm, both clinical and psychological, by misusing these tests.
Yeah, this is a really high-stakes discussion. That impulse to work up a younger patient who comes in with a clot, it's universally strong, right? You feel like you should look for something. But the data, and particularly the most recent American Society of Hematology, the ASH 2023 guidelines, they strongly push back against doing this routinely in patient. So we need to explore both the molecular basis of these conditions and also the logistical reality of why testing during an acute illness just makes the interpretation so unreliable.
I completely agree. The guidelines seem firm, yet the practice just persists. So before we dive right into that conflict, let's maybe start with the basics. Let's define thrombophilia itself. What exactly are we even looking for when we order this whole battery of tests?
Okay, so thrombophilia is basically defined as a group of conditions. They can be inherited or they can be acquired. And what they do is confer a demonstrably higher than normal risk of developing VTE. So that could be a deep vein thrombosis or pulmonary embolism.
And when we look at the hereditary components, the focus seems quite specific. It centers on defects in the body's natural checks and balances for the coagulation cascade, right?
Precisely. The key inherited conditions really fall into two main groups. First, you've got the deficiencies of the natural anticoagulants. So that's antithrombin, protein C, or protein S. These are typically the ones we worry about most in terms of VTE risk. Second, we look for what we call gain-of-function mutations, the ones that actually promote clotting. Specifically, that's factor V Leiden, or FVL, and the prothrombin gene mutation, PGM G2210A. These mutations essentially make the coagulation factors either resistant to being broken down or they cause them to be overexpressed.
Okay, so that covers the inherited side of the risk. Now, on the acquired side, the single most critical element we test for, especially given its profound impact on long-term management and recurrence risk, that's antiphospholipid syndrome.
Absolutely. Antiphospholipid syndrome, or APS, is the primary acquired thrombophilia we're concerned about in this context. To identify it, we look for persistent positivity of three specific antibodies: lupus anticoagulants, anticardiolipin antibodies, and anti-2-glycoprotein-1 antibodies. And it's really crucial to remember that APS, unlike most of the inherited defects, often requires indefinite anticoagulation. That really elevates the stakes of making this diagnosis correctly.
So we have this pretty comprehensive list of known defects, but here's where we hit that core conflict. VTE seems highly heritable. I've seen estimates up to 60%. Yet the guidelines warn strongly against testing. If genetics plays such a huge role in predisposition, why is that instinct to test, especially in the acute setting, considered fundamentally flawed?
Yeah, this is where we really need to distinguish between the predisposition to VTE and the actual provocation of a specific VTE event. While the tendency, the propensity for VTE is highly heritable, those known genetic defects we just listed, they actually account for only about a third of those VTE cases overall. And if we look specifically at large population registries, these inherited thrombophilias like FVL or PGM, they account for only about 5% of all VTE events.
5%, wow. That's a striking minority.
Yeah.
It really tells you that in the hospitalized patient population, which is where we encounter most VTEs, the ultimate trigger, the straw that breaks the camel's back, it's overwhelmingly something acquired or multifactorial. It's usually not the inherited defect itself, even if it's there.
That's the critical distinction, exactly. The vast majority of VTE we see in hospitalized patients is provoked by common, often powerful, acquired risk factors. We're talking about things like active malignancy, significant trauma or surgery, major immobility, or obesity. In the context of an acute hospitalization, these factors are just far, far more common triggers than a single inherited defect.
Which brings us right to the core consensus and that major guideline update from ASH in 2023. Why are they so unequivocal in recommending against routine inpatient thrombophilia testing for acute VTE?
They really cite three major reasons, and they're all kind of interlinked. First, there's just minimal clinical utility in the acute phase. The results usually don't change what you do right then. Second, there are documented high rates of inappropriate ordering. Multiple retrospective studies have confirmed this. We just order it too much when it's not indicated. And third, maybe most damagingly, there's a really high frequency of false or misleading results because of all the confounding factors, which I know we'll get into.
Okay, let's focus on that minimal utility aspect first. If a patient comes in with, say, a pulmonary embolism, the initial management full-intensity anticoagulation that's not altered by whether they happen to have active or not, right?
Exactly. The acute decision to anticoagulate is driven entirely by the VTE diagnosis itself. Testing for thrombophilia doesn't change that standard treatment path while they're in the hospital. So if the test isn't going to change your acute clinical decision, then you're just incurring unnecessary costs, you're consuming specialized lab resources, and potentially you're delaying the true diagnosis or muddying the waters with a result that might be false anyway.
And that risk of overdiagnosis.
Mm-hmm.
It's a major ethical and practical concern. I actually remember a case from residency where a transiently low protein S level picked up inpatient led to completely unnecessary lifetime anxiety for the patient. It even affected their ability to get mortgage insurance later. The harm goes way beyond just the medication cost.
You've really highlighted the crucial element there, the harm. Mislabeling a patient with a lifelong inherited risk based on an unreliable test taken at the wrong time. It has serious cascading consequences. It leads to unnecessary lifetime surveillance, potentially incorrect decisions about long-term anticoagulation down the road, and as you said, profound psychological distress. In those retrospective studies, they confirm that very few inpatient tests are actually appropriately indicated or ultimately lead to any relevant change in clinical management. Most often, they just generate noise and confusion.
So if the acute environment's truly this hostile to getting accurate testing done, the question shifts pretty quickly from why not test to really when not to test.
Yeah.
This leads us directly into the pitfalls of timing. Why does the acute thrombosis itself, and just being hospitalized and sick, wreak such havoc on these laboratory results?
It absolutely does. The acute phase of VTE and hospitalization represents a highly inflammatory state. We call these the acute confounding factors. Acute thrombosis itself involves the consumption and utilization of coagulation factors. Then you add acute illness and systemic inflammation on top of that, and they further transiently alter the levels of key proteins. It leads directly to unreliable results.
Can you give us some specific examples? How does the body's own natural response to having a VTE create these sort of acquired transient deficiencies that look like the real thing?
Yeah, the primary issues are with those natural anticoagulants we mentioned, protein C, protein S, and antithrombin. During an acute illness, their systemic activation and consumption process is happening. For example, protein C and protein S are actually consumed during the propagation of the clot itself. So their measured functional levels can be artificially low just because of the acute event. This transient acquired deficiency perfectly mimics a true permanent inherited deficiency. If you test somebody in that dynamic state, you are highly likely to get a false positive result for a true inherited defect that simply doesn't exist.
And beyond the illness itself, the intervention, the anticoagulation therapy we start immediately, that also significantly skews results, particularly for the functional assays.
Right.
Let's maybe start with warfarin, which is still pretty widely used.
Oh, this is a major challenge, especially for the inpatient team, because warfarin, being a vitamin K antagonist, prevents that necessary gamma carboxylation that's required for the vitamin K-dependent factors to function properly. And this includes protein C and protein S. So if you test a patient who's receiving warfarin, you're essentially measuring non-functional factors. You're measuring an acquired functional deficiency caused by the drug. You are highly likely to get a false positive diagnosis of protein C or protein S deficiency, regardless of the patient's actual underlying genetic status.
Right, so we're not necessarily seeing less protein, the levels might be normal, but the protein that's there simply isn't working because warfarin has inhibited that modification it needs to operate in the cascade.
Precisely. You're measuring non-functional factors. And the interference doesn't stop there. Heparin, which is a mainstay in acute VTE treatment, can also interfere directly with antithrombin measurements. Since antithrombin assays often rely on measuring AT activity through its effect on factor Zea, adding therapeutic heparin, which naturally enhances AT function, can sometimes artificially lower the measured baseline AT level or just lead to really complex interpretation challenges in the functional assays. It creates uncertainty.
And now with the rise of the direct oral anticoagulants, the DOACs, are they innocent when it comes to interfering with testing?
Unfortunately, no, they're not innocent either. DOACs, whether they are factors IX inhibitors or direct thrombin inhibitors, can interfere significantly with clot-based assays. This includes functional tests like the activated protein C resistance testing, which is often used as a screen for factor V Leiden. Their presence in the plasma means that any functional testing has to be either very carefully timed, which is really difficult to do acutely, or, more realistically, just avoided entirely while the patient is on them, because the results are often completely unreliable.
Okay, let's circle back for a second to antiphospholipid syndrome. We mentioned that APS testing is a key part of the panel, but its really strict diagnostic requirement related to timing is perhaps the clearest argument for deferring the test.
That is absolutely critical for APS. To diagnose antiphospholipid syndrome reliably, you need persistent positivity. The diagnostic criteria require that those specific antibodies, the lupus anticoagulant, anticardiolipin, and antibopoglycoprotein 1, must be positive on 2 separate occasions, at least 12 weeks apart. If you test too early, the acute illness itself or the inflammatory state can actually cause transient positive results that do not represent a true, persistent autoimmune condition. You need that time interval.
Wow. Okay, so this confluence of acute confounding factors from the illness, the consumption from the clot, and then the therapeutic interference from anticoagulants, it really presents a powerful argument for delaying this testing. So what is the consensus then on the optimal timing for a reliable workup? When should we be doing this?
The consensus is clear. Testing must be deferred until after the acute phase has fully resolved and, ideally, after anticoagulation has been discontinued. The standard recommendation is typically to wait until after 3 months of therapy for a first VTE event. And this timing is quite deliberate because it coincides with that crucial moment when clinicians are making definitive decisions regarding the duration of long-term anticoagulation. Are we stopping or are we continuing?
So deferral achieves 2 critical goals then. First, clinical accuracy, by removing all those acute confounding factors and interferences. And second, clinical meaningfulness, by timing the result to arrive exactly when it actually impacts a long-term decision. The result essentially moves from being potentially misleading noise during the hospitalization to being potentially actionable data later on.
Precisely. If we wait, the result is much more likely to be accurate, and it arrives just when you're grappling with that decision. 6 months of therapy versus indefinite therapy. That's when the result truly justifies the cost, the effort, and the potential implications of the testing.
Okay, so if the acute environment is this hostile to accurate testing, and if the gold standard is deferral for at least 3 months, the question naturally shifts from when to who. Who are the select few patients where this high-stakes testing is actually worth the future risk assessment and the logistical effort involved? This moves us squarely into identifying those high-value scenarios for selective testing.
Right. The rationale here really has to be non-negotiable. Testing is only appropriate when 2 conditions are met. First, the pre-test probability of finding a clinically significant thrombophilia must be reasonably high based on the patient's story. And second, the results must have a real potential to definitively influence long-term care decisions or provide necessary family counseling. We have to screen our patients based on rigorous clinical context, not just test everyone.
So what are those specific high-yield clinical indications that should make us think, okay, this person warrants a workup, even if that workup is scheduled for 3 months down the line?
The guidelines are actually very specific about this. First, VTE occurring at a young age. Typically, this is defined as less than 40 or maybe 50 years old. The younger the patient, the less likely they are to have those powerful acquired risk factors like active cancer or recent major surgery, which increases the relative likelihood that an underlying inherited defect might be playing a role. Second, we look for recurrent VTE, or VTE that's classified as idiopathic, meaning it was unprovoked or maybe associated with only very weak provoking factors. An unprovoked clot strongly suggests an underlying hypercoagulable state.
And a third strong indicator is location, isn't it? The site of the clot matters.
Yes, absolutely. Thrombosis occurring at unusual sites is a major indication for considering testing later. We're talking about things like cerebral venous thrombosis, splenic vein thrombosis, or portal vein thrombosis. These specific sites are statistically much more highly associated with underlying thrombophilic defects and really require focused investigation.
And familial history. That seems like an obvious one, too.
It is. A strong family history of VTE, especially in first-degree relatives, parents, siblings, children who experienced events before the age of 50, that's a major trigger for investigation because it strongly suggests a potentially penetrant, inherited defect running in the family. And finally, VTE that's related to pregnancy, the postpartum period, or estrogen use often warrants testing, but only if the results would genuinely alter future management decisions regarding hormones or prophylaxis during future pregnancies.
Okay, but here's a logistical challenge that always comes up. If we correctly identify, say, a 35-year-old with an unprovoked DVT, and we decide, yes, testing is necessary down the line, doesn't deferring that test for 3 months significantly increase the risk that the patient just fails to follow up. They leave the hospital, life happens, and the test never actually gets done. Are we kind of sacrificing compliance for accuracy here?
That is the real-world failing point of this strategy, and you raise an absolutely critical practical point. While deferral is scientifically necessary for accuracy, it definitely places a burden on patient follow-up systems. This is precisely why the guidelines really stress the role of expert consultation during the acute hospitalization phase. Getting expert consultation, usually with hematology, is crucial because specialists can ensure appropriate counseling is done up front, they can help schedule the delayed testing, and critically, they can manage that necessary bridge between inpatient discharge and outpatient follow-up to make sure it happens.
Ah, okay. So the role of the expert here isn't necessarily to run the test acutely, because we know that's problematic, but rather to act as the mandatory gatekeeper and long-term scheduler, ensuring the loop gets closed later.
Precisely. Specialists are far more likely to adhere to the guidelines, to ensure the timing is appropriate, and importantly, to prevent that unnecessary and inappropriate testing that might just confuse the long-term clinical picture. It adds a necessary layer of scrutiny and planning to enforce that deferral effectively.
That sets the stage perfectly for when we should test, albeit deferred. Let's move now into the specifics of the laboratory workup itself. Assuming a patient meets those high-value criteria we just discussed, what are the specific components of that recommended targeted workup? What should actually be on the order form?
Right. The recommended panel, as laid out by ASH, needs to be really focused only on those clinically relevant conditions we identified earlier. If we start ordering things outside this core scope, we just increase cost and generate noise without adding clinical value.
Which means specifically?
Okay, so for the inherited defects, we stick to the core 5. That's the factor V Leiden mutation, the prothrombin gene mutation, PGM G202010A, antithrombin deficiency, protein C deficiency, and protein S deficiency. And then for the acquired side, it's the full antiphospholipid syndrome panel. So lupus anticoagulant, anticardiolipin antibodies, usually IgG and IgM, and anti-2 glycoprotein 1 antibodies, again, usually IgG and IgM. That's the recommended set.
And it seems vital here that we differentiate between the testing methods used for these, as that distinction really dictates which tests are potentially safe to run acutely, which you've argued is almost none, and which absolutely must be deferred.
Yes, that is a critical point that every inpatient provider must internalize. For the deficiencies, antithrombin, protein C, and protein S, we have to use functional assays. These assays measure the actual activity of the proteins in the coagulation cascade. And as we've discussed extensively, their activity is profoundly affected by acute illness, inflammation, consumption, and by anticoagulation. So these are the tests that absolutely need to be deferred. The consequence of running a functional assay acutely is potentially devastating. A patient with a transient dip due to illness but no true genetic defect gets labeled with lifelong protein S deficiency. This could lead to years of unnecessary worry, counseling, maybe even inappropriate anticoagulation.
Conversely, the genetic testing seems much more robust, right? It doesn't really matter what the patient's acute status is or what medications they're on, because we're looking directly at their fixed DNA sequence.
Exactly. Genetic testing, specifically using PCR analysis, is used exclusively for the prothrombin gene mutation, PGM G202010A. It's also the standard confirmatory test for factor V Leiden, usually done after an initial abnormal activated protein C resistance screen might suggest it. Since these genetic tests look for the DNA mutation itself, they're minimally affected by the acute inflammatory status or by concurrent anticoagulation. However, even though these tests are reliable acutely, the recommendation is still generally to defer them along with the others, unless there's some incredibly pressing reason not to, mainly to reinforce the standard of care and the principle of deferral for the whole panel.
Okay. And are there any tests that sometimes get ordered maybe out of habit or confusion, but are explicitly not recommended by ASH because they just lack clinical value in this setting?
Yes, ASH is quite clear on avoiding tests for certain other genetic markers that have fallen out of favor. This definitely includes MTHFR polymorphisms. These were widely tested for years, but extensive study has shown they lack clinical relevance in changing VTE management decisions. Testing for them just adds cost. They also advise against routinely testing for elevated factor VIII, factor IXX, or factor LEI activity unless there's a very specific clinical suspicion, which is rare. Keeping the panel focused is really key to avoiding unnecessary noise and expense.
Now we come to perhaps the most challenging part for the clinician who eventually gets these results back, interpreting them correctly and avoiding those diagnostic pitfalls. We've established the acute phase is chaotic, but even beyond that, maybe when tested later, What are some common medical conditions that can cause acquired deficiencies that might still mimic an inherited thrombophilia?
Interpretation requires a true synthesis. You need the lab result, the patient's specific clinical scenario, and the timing of the test all considered together. We must constantly be aware of the potential for false positives caused by other systemic conditions. For instance, significant liver dysfunction can impair the liver's ability to synthesize multiple coagulation factors, including antithrombin, protein C, and protein S. This leads to genuinely low functional levels, but it's acquired due to the liver disease, not inherited.
So in that case, the problem isn't consumption during a clot, but rather a failure of production by the sick liver.
Correct. The failing liver just can't produce enough of these proteins. Conversely, in conditions like nephrotic syndrome, where patients lose a lot of protein in their urine, we often see urinary loss of smaller proteins. Antithrombin happens to be a relatively smaller protein, so it can be filtered out by the kidneys and lost in the urine. This can lead to an acquired, potentially transient antithrombin deficiency that could easily be mistaken for a lifelong inherited defect if you weren't aware of the nephrotic syndrome context.
That's a fascinating example of how a completely different systemic illness can perfectly mimic a specific genetic defect on paper. So, how does the clinician maintain a high index of suspicion for a true inherited defect amidst all this potential confusion from acquired causes?
The clinician absolutely must use the clinical features to contextualize the lab findings. A high index of suspicion for a true inherited defect has to be supported by those specific characteristics we outlined earlier. The patient being young, having the thrombosis at an unusual site like cerebral or splanchnic veins, or having that strong multi-generational family history. These features help lend weight to a low laboratory reading actually representing something real and inherited. On the other hand, if the clinical picture is absolutely classic for a highly provoked VTE, let's say, a patient immobilized after major abdominal surgery, then finding a slightly low protein S level is statistically much more likely to be just an acquired, transient finding related to the acute event, not a true hereditary deficiency that requires lifelong concern or management changes.
It really sounds like the rationale for this very focused, deferred approach is paramount. It's all about avoiding unnecessary testing in the first place, reducing the chance of misdiagnosis from transient changes, and ultimately ensuring that the final, reliable result, when obtained, is actually clinically actionable for making those crucial long-term management decisions. The delay fundamentally prevents the mislabeling of a patient based on what might just be a transient physiological snapshot taken during a very stressful time.
Mislabeling is the ultimate harm we are trying to prevent here. Once a patient gets entered into the electronic health record, maybe gets told they have an inherited thrombophilia diagnosis based on a faulty test, it impacts their healthcare trajectory, potentially their insurance eligibility, and certainly their psychological well-being, sometimes for decades. We have to get it right.
Okay, let's transition then to our final section, focusing on the clinical implications and long-term management, which, as you said, is the whole point of considering testing in the first place. We've clearly established that thrombophilia status has minimal, if any, immediate impact on inpatient management.
That's probably the core takeaway for hospital providers listening. Your immediate management is standard VTE, anticoagulation heparin, DOAC, whatever you choose, and it is not changed by finding out if the patient has factor V Leiden or low protein C acutely.
So if the initial management is exactly the same regardless, how does the eventual identification of a specific defect, when tested appropriately later, actually influence the long-term decision-making process for that patient?
The primary focus shifts entirely to defining the necessary duration of anticoagulation after the initial treatment period. Identifying a strong thrombophilia, for instance, something like antithrombin deficiency, which carries a very high risk, or maybe the presence of multiple defects, like being heterozygous for both FVL and PGM, or having APS. This may significantly influence the decision towards recommending extended or even indefinite anticoagulation. This is particularly true if the initial VTE was unprovoked or only weakly provoked. The stronger the underlying defect, the higher the estimated recurrence risk of anticoagulation, and therefore the greater the potential benefit and justification for continuing long-term therapy.
And the ASH modeling work seems to try and quantify this benefit, right? While maybe modest in absolute terms, it does provide some tangible numbers for discussing risk with the patient.
It does. The ASH modeling suggests that the absolute benefit of testing appropriate patients and then extending anticoagulation in those found to have a significant thrombophilia is around preventing approximately 21 recurrent VTE events for every 1,000 patients treated with extended therapy per year. Now, that's a significant preventative effect when you consider the morbidity and potential mortality of recurrent VTE. It really justifies the high stakes of getting the diagnosis right through appropriate timed testing. The main impact is one of future risk mitigation, specifically preventing that future, potentially fatal recurrence.
Let's take a moment to discuss the special populations, where testing, even though it should still be deferred, might be particularly crucial because the results impact future non-thrombotic decisions as well. Women of childbearing age seem like the prime example here.
They are perhaps the single most important special population to consider because the results can profoundly influence their reproductive planning and hormonal choices throughout their lives. The results of thrombophilia testing might dictate critical decisions regarding the safety of hormonal contraception, the management strategy during pregnancy, like prophylactic anticoagulation, and the need for postpartum prophylaxis. For example, a woman found to have the factor V Leiden mutation might be strongly advised against using estrogen-containing oral contraceptives due to the multiplied risk. Contrast that with a woman found to have antithrombin deficiency. She faces an even higher baseline thrombotic risk and would likely require extremely aggressive anticoagulation prophylaxis during any future pregnancy and the postpartum periods.
So the knowledge fundamentally changes the risk calculus for future events entirely. You might not be changing the duration of anticoagulation for her current VTE event if it was clearly provoked, but you are enabling highly targeted preventative strategies during future high-risk life phases like pregnancy or potential hormone use.
Exactly. Even if the presenting VTE was clearly provoked by, say, an orthopedic injury requiring immobilization, the identification of a strong underlying defect allows us to proactively mitigate the risk of future, potentially devastating provoked events associated specifically with pregnancy or hormones later in her life. And similarly, as we touched on, patients who present with those unusual site VTEs, the cerebral vein thrombosis or the splenic vein thrombosis, they generally must be tested. Again, deferred testing. The high association with underlying defects in these cases often translates directly into a decision for indefinite anticoagulation, making the testing highly relevant.
Okay, so to wrap things up, let's just quickly summarize the three core strategies that we, as hospital medicine clinicians, must employ consistently to avoid the common pitfalls with thrombophilia testing that we've detailed so thoroughly today.
Yeah, the strategies are pretty clear and really need to be institutionalized, ideally built into order sets or pathways across every hospital system. Number one, limit testing strictly to only those patients who meet the specific high-risk clinical criteria we discussed: the young patient with unprovoked VTE, the recurrent VTE patient, those with unusual site thrombosis, and those with a compelling family history. Number two, always defer the testing. Defer it until after the acute phase is completely resolved and after anticoagulation is completed, which is typically around the 3-month mark. Resist the urge to test inpatient. And number three, ensure the results, when they are eventually obtained, are interpreted by clinicians with expertise in the area and always coupled with appropriate pre-test and post-test counseling for the patient, specifically to avoid misdiagnosis and prevent unnecessary long-term anxiety or harm.
This has been an incredibly detailed and helpful review. It really grounds those strong guideline recommendations in the physiological reality of coagulation system chaos during acute illness. It strongly highlights the clinician's responsibility, our responsibility, to be the thoughtful gatekeeper for these high-stakes, often expensive tests, prioritizing accuracy and patient well-being over the temptation of speed or just ordering something because we can.
Absolutely. And maybe the final provocative thought for everyone listening is this. We really must ask ourselves, given that we know acute illness and inflammation can cause these transient, misleading deficiencies of natural anticoagulants, what are the true ethical and clinical consequences of diagnosing a lifelong, heritable defect based on a single snapshot test taken during the most dynamic and physiologically chaotic phase of a patient's life?
That really raises a critical systems-level question that hospitals and healthcare systems need to address. What formal mechanisms can our institutions actually implement, things like mandatory hematology review for ordering or hard stops in the EMR, to enforce deferral and ensure expert oversight for this specific, costly, and high-stakes panel? How do we ensure we are truly minimizing iatrogenic harm from inappropriate testing?
That is the ongoing challenge for hospital systems and all of us as providers moving forward, making the right thing to do the easy thing to do.
Well, thank you so much for joining us today for this really important deep dive into inpatient thrombophilia testing.